Hi, this is Junaid, and we are now on the last section of the acute ischemic stroke guidelines, in which we're going to discuss secondary stroke prevention. The first of the series of 3 lectures will include the secondary stroke prevention of what kind of imaging you need, what kind of vascular imaging you need, etc. So let's get on to it. The first and the foremost is that one of the key recommendations over here is that some patients, not all patients, do need MRI. And the concern over here is that, for me personally, has always been, is it a subacute infarct? It is actually a subcortical infarct or a cortical infarct, because the therapy changes. If it's a cortical infarct, then I'm looking into more of an embolic pattern. If there's an embolic pattern, then we have to consider getting PFO studies, potentially other kinds of studies, cancer treatments, loop recorders, etc. So in some patients, when you are actually on the edge, if you are actually not sure if the patient has an embolic infarct or a subcortical infarct, that could be the key problem. Subcortical infarct can also present with aphasias. So therefore, it is very important in your situation that if it is a clear-cut patient is a smoker, hyperlipidemia, hypertension comes in with numbness, dysarthria, etc., and no large vessel sort of signs, then MRI may not be necessary. However, in some cases, as noted here, the class of recommendation is now 2A. Look at the level of evidence. The level of evidence is actually C. Similarly, if the patient is actually an appropriate candidate for PFO, which is very, very small category of patients, I'm going to be very honest with you. In my whole career, I have had 3 PFO closures, and those were pretty slam dunk. Otherwise, I have done a proper workup in all 3 of them for 6 months with loop recorder placed to actually make sure that they do not have any arrhythmias. So when you have to consider that, by the way, there's another lecture that I'm going to put in according to the new American Academy of Neurology guidelines on PFO closure. So stay tuned for that. But as you can see, in those patients, eligibility criteria is requirement of MRI. So if you are thinking of that particular portion, please do get an MRI. And then the effectiveness of an MRI to guide the therapy, again, it's uncertain. Clearly, it's uncertain because most of the cases, if you're going to see that, if it's a small vessel disease, slam dunk, do you really need an MRI? Not really. So in those cases, you have to make sure that you're judicious and producing value for the system as well. As far as the vascular imaging is concerned, for non-disabling strokes, vascular imaging of the carotid is period. You have to get it. There's no question around it. You can consider using carotid ultrasound. However, CTA is definitely better. Intracranial vessel imaging, again, is reasonable to consider in these patients. Again, the level of recommendation, as you can see, is C level because the evidence is not there. But if you can see, the class of recommendation is 2A. So in those patients that you are considering, we actually, we are taking vascular imaging. Initially, when we looked at the data from 2014 to 2018, it was only around 56% or so. But more recently, we have been getting vascular imaging potentially mostly via CTA and doing it earlier than later, because these patients technically tend to come in the ER, and then when they are in the acute stroke phase, within the 24-hour window, subocclusive clots need to be ruled out in some cases, so we end up actually getting CTAs now more frequently. However, as you can see, the class of recommendation is only 2A. Same thing, atherosclerotic plaque in the major internal carotid artery, as you can see, those patients clearly can differentiate. Previously, I'm going to come to that in the next lecture about the antithrombotic therapy. We used to select for Sampras, and we need to find out what is the intracranial atherosclerotic disease burden. But now, in general, when you can see these patients, the recommendations have slightly changed, and dual antiplatelet therapy for mild non-disabling strokes is on the get-go for 21 days. Sampras is 90 days. So clearly there's a difference, but finding out intracranial atherosclerotic disease is sort of is a biomarker for stroke patients and the further risk of having stroke or not. So in general, I do pursue intravascular imaging on a routine basis. And however, it is not highly recommended, as you can see, according to the level of evidence in the class of recommendation. Cardiac evaluation, Definitely you need telemetry. There's no question about it, especially in the first 24 hours. Believe it or not, the highest detection rate is the first day after the stroke. So first 24 hours, there is no question about it. Effectiveness of long-term monitoring, it depends on the patient to patient. In general, if the patient has obstructive sleep apnea, significant alcohol abuse in their history, or have CABG or CAD done, those kind of patients, I actually select them according to the patient risk factor, and clearly, of course, they have an embolic infarct. On those patients, we do long-term cardiac monitoring. However, it is not recommended in all patients. Echocardiography, as you can see, these are also recommended in only some patients. From our protocol, and to be honest with you, wherever I have seen echocardiography is done as a standard procedure on all these patients, and you should potentially consider them. One of the indications that we see is that left atrial size, and that can actually point to the risk of development of atrial fibrillation. So it is useful information. Those patients who are coming with embolic infarct, absolutely, you need an echocardiogram. No questions asked. You need to make sure there is no intramural thrombus, and you need to make sure, because that definitely changes your therapy for the patient. Glucose monitoring is important. As I said, for only one test you need is an acute ischemic stroke is glucose, but as far as the secondary stroke prevention is considered, you need hemoglobin A1C on these patients. Other tests that are important, as I said, as you can look at it, there's really no other important test that needs to be done, including thrombophilic studies. As you can see, the class of recommendation is 2B, obstructive sleep apnea, antiphospholipid antibodies, homocystinemia. All these things are not recommended anymore on a regular basis. Of course, you can choose according to your patient's risk. Thanks for your time. Please like, subscribe, and share. Follow me on LinkedIn and Twitter.